All right, we're going to get started. Good morning, everyone. We're excited to have you here. My name is Kirsten Olson. I'm the marketing director at BD for all the vascular access devices. Thank you for joining us today for today's presentation by Dr. Wesley O'Neill and Michael Bachman on the fenestrated intravenous catheter use in CCTAs. I would now like to introduce our speakers. Wesley O'Neill, Dr. Wesley O'Neill, is a non-invasive cardiologist with Cone Health in Greensboro, North Carolina, where he serves as the medical director for cardiac CT and nuclear cardiology. He completed his cardiovascular disease fellowship training at Emory University in Atlanta, Georgia. He's board certified in cardiovascular disease, cardiovascular CT, adult echocardiography, and nuclear cardiology. He has an active interest in promoting and increasing the use of cardiovascular CT to improve patient outcomes and healthcare resource utilization. Michael Bachman is the CT supervisor at Moses Cone and the system-wide cardiac imaging specialist for Cone Health. Dr. O'Neill, Michael, we are very excited for your presentation today. I'll now turn it over to you.
So thanks for having us, and thanks for letting us kickstart your SCCT this year. A little bit of a different thing to talk about from what you'll see here over the next few days, but we're going to talk about our experience with fenestrated catheters. You may or may not be aware of what you use at your institution, but you should reach out and find out what your CT techs are using and what your institution does. It's just a new way of thinking about maybe how you do it, or maybe you can learn something to improve what you do in practice already. Here are the disclosures. So the objectives of this talk are, first off, to discuss our use of fenestrated catheters, or if you use them or familiar with them, this may be a refresher for you. Kind of discuss the importance of high injection rates. Really want to limit that contrast to noise ratio, and this can really help you do that, especially if you're struggling with image quality. We also do want to talk a little bit about how this can help you imaging larger patients with larger BMI. We're in North Carolina. We've had to figure out how to image larger patients. We also are Michael's going to talk more about kind of our center's experience with the fenestrated catheters, kind of a before and after look of what we used to do and what we do now, and how it's kind of helped us be better at what we do. So this is pretty clear. This is straight from the SCCT guidelines about acquisition parameters, kind of what we should be doing. Clearly, whenever we're acquiring cardiac CT images, we really want to make sure the heart rate's well controlled through beta blockade or calcium channel blockers. Heart rate's less than 60. You may get by with a dual source scanner a little higher, depending what you have. You really want to be cautious of the radiation you give the patient. The KV is the easiest way to really reduce radiation, being aware of how much you're giving each patient. Nitrate's pretty clear. We want maximum vasodilation. That's really important for coronary CTA analysis as well as FFRCT. You really want to optimize your contrast tracking. You could either do test bolus. We do tracking at our institution. We warm the contrast, and really what's recommended is a high injection rate. And I think most people are familiar with 5 cc's per second, but when you go above that, some of your comfort levels may be a little varied in how you do things. But what is recommended, and this is a guideline statement in 2022 on coronary CTA in the emergency department, and you may or may not be aware of this, but it is recommended to use fenestrated high-flow IV access catheters, especially when performing CCTA. This is really going to help really increase the attenuation in the vasculature and give you much higher attenuation or much higher contrast to noise when you're actually looking at your images. So how can BD or Diffusix, the Diffusix brand, help you? And what are these catheters? These are fenestrated catheters. Unlike a typical angiocath, which has one bore, when you inject it goes to the tip of the catheter. These fenestrated catheters are what they are. They're fenestrated. They're going to allow multiple contrast jets to come out, and that's really going to allow you to have a higher injection rate. You're not going to pressure lock as often as other vendors or other catheters that don't have this technology. And another thing that's really nice about the entire product line is you can actually down gauge, meaning you can probably inject at a higher rate what you'd get with an 18 gauge angiocath with a smaller catheter. So in patients who have difficult vascular access, you can't get a larger catheter in, this is really going to help you. But that's kind of what the technology is. These fenestrated holes are going to allow for higher injection rates, less pressure locking, and let you get a much tighter contrast bolus when you're doing coronary CTA. These are just some specifics about the product line or the diffuse catheter, the standard link catheters, I should remind you. And this just goes through the catheter size, which is available, the maximum pressure limit, as well as the maximum flow rate. So with an 18 gauge, for example, you can inject up to 15 cc's per second quite reliably, at least what's reported. And the same thing with a 20 gauge, you can inject up to 10 cc's per second. Rarely are you going to get above that with cardiac CTA, but this is just available to you in a safe manner, especially with the Fenestrated technology. So what about the diffuse catheter or these Fenestrated catheter systems? How do they help you? How do they do this? Well, really, they reduce motion. You know, the technology itself is going to allow the catheters to not move as much, so it's not going to pressure lock as much. It's not going to hit the vessel wall. That's really good for high injection rates. There's a reduced radial force or force in general with the technology. So this is just going to be, you know, in comparison to these non-diffusion tip catheters, it's really going to allow less motion and less radial force is the way I think about it. And this is all from animal studies. Which have kind of been shown that, but we've seen that in practice too. You can really reliably inject at higher rates and not have to worry about, you know, devastating complications, which we'll talk about on the next slide. So I think this is the real reason why we've adopted this at our institution as kind of standard of care. You know, you really want to avoid any extravasation accidents or adverse events. These can be quite costly for the health system. And you really want to make sure you're aware that you're using catheters, especially in CCTA, that are going to reduce that burden or the risk of that happening. Just some potential costs that can occur or incurred by the health system could be up to $20,000 of liability for a moderate event or a moderate adverse episode, but nearly you can have up to $140,000 if you have a severe episode. Maybe the patient has to be admitted or has to have a procedure to actually correct that adverse event. So these are just things to think about when you're building your program, designing the whole program from top to bottom. So now a little bit into the science, why this is important. And I think everybody in the room attending the conference is quite aware that you really want high contrast to noise ratio or high CNR. You can see here on the left side, and this was a larger patient at our site, the higher the contrast rate, the tighter that bolus is, the more attenuation you're going to get in the vessel. And you can see here it's up to 578 Hounsfield units. You can really delineate the noise, the small attenuation vessels or the soft, the fat there, all these other things really don't matter because you've got really good attenuation in the vessel itself. And you can contrast that to the image on the right or your right. Very low injection rate, low attenuation in the vessel. You really, you know, when you get down to the distal vessel, you really don't know if you're actually looking at blood vessel or you're actually looking at fat or subcutaneous or other tissues that's there. So really the whole goal of coronary CTA, no matter what you do, is to really have higher CNR and really make sure you're evaluating the vessel in its totality. And this is just a study, I think this was done in Asia, using fenestrated catheters that allow for these higher injection rates that we're talking about, higher contrast noise ratio. And it just compared fenestrated catheters to non-fenestrated catheters. And this just measured the attenuation or the Hounsfield units in the ascending aorta, left main, LV cavity, and descending aorta. It also looked at the PSI, or the pounds per square inch per the injection. But you can really see in the fenestrated catheters, which are shown in kind of the light gray, you're going to have much higher attenuation in the ascending aorta, as well as left main, LV cavity, descending aorta, pretty depending where you put your marker. And you're actually going to have much lower PSI or lower pressure with the fenestrated catheters. So you're going to achieve what you're setting out to do. Higher injection rate is going to give you a tighter bolus, more attenuation, and you're not going to pressure lock out. You're going to have lower pressure in the vessels. So it's really going to give you nice, high quality, clear images. And then this is just some images from our institution as well, just highlighting the impact of improved outcomes. We really want to have high quality images that allow you to evaluate the anatomy very well, and then that's going to go on down to FFRCT if you use that at your site, as well as to the cath lab. And this is just a great case of high quality images, high injection rate, high CNR, just nice quality that allowed for accurate FFRCT as well as accurate coronary angiography, as this patient had a pretty tight lesion in the proximate to LAD and he underwent intervention. I think We also are very aware of plaque characterization. This is now becoming the hot ticket item, especially for prevention as we move away from maybe calcium scoring and moving into the plaque analysis arena. But you can really see when you have higher contrast opacification or higher attenuation in the vessel, you can see what you're looking at much better. You can post-process easier, you can do all these things. And then this is just a nice case highlighting calcified plaque, soft plaque, as well as low attenuation plaque, which you can see quite nicely. And you can even see that, that really low, less than 40 attenuation plaque. I don't know if this is going to work right here in the middle. But, you know, the moral of the story is high-quality images are really going to let you diagnose accurately FFRCT plaque characteristics as well. So I'll just go through some cases because I think these are important and kind of highlight kind of our move to diffusics and how it's helped us. Really, I think this was a 20 or something year old kid, and he was basically ordered for anomalous coronary evaluation. So they just wanted to make sure he didn't have an anomalous coronary takeoff. And basically, we really wanted to reduce radiation in this patient, but we really wanted to see the distal vessels and just see it all well, just because we use this not too infrequently in practice. So this patient underwent a CCTA with an 18 gauge diffusics at about 7 cc's per second. It was at 70 kV. Now, this was a high-pitch helical scan, so the kV is only going to be so high in this, but it was lower than what you can select for that scan. And really, the opacification in the aorta was up to 979 Hounsfield units, which is really high. It's nice for this guy because, you know, we really wanted to just rule out anomalous coronary, so we didn't need to see a whole lot. But you can really see the entire distal vessels. So you can imagine if this was another patient who you wanted to evaluate for coronary disease or epicardial stenoses, you would still get that information. Now, the radiation is going to be very low anyway with a high-pitch helical scan, but really I think that this case just highlights the high attenuation in the vessels. You can see what you need to see and really diagnose correctly. This was another patient. This was not someone done for a coronary anomaly, but this was a 50 or so year old patient who was done for routine chest pain, stable chest pain in the office. We used an 18 gauge diffusics at 7 cc's per second. And we actually did not increase the kV. We kept it at 70 for this case. We've kind of explored lower kV levels. Again, really didn't think this patient would have coronary disease, so we really wanted to reduce the radiation. It can affect your plaque analysis and other things, so you want to be cognizant of that. But in someone who's got no calcium, very low risk, you probably could get by with lower kV, as shown in this study. And this patient was actually scanned prospectively from 35 to 75%, late systole to early diastole. The Hounsfield units or the attenuation in the aorta were very high at 1800. And really, even for a prospective scan in late systole through diastole, you really have low radiation, only 1.5 millisieverts. So really just increasing your flow rates, having higher attenuation can really save you with radiation, especially if you choose a lower kV. And this was able to see all the distal vessels very nicely. This patient had normal coronaries. This is another case, 50-something year old man, stable chest pain symptoms. Again, standard things that you'd send for coronary CTA. 18 gauge diffusics at 7 cc's per second. We actually selected 80 kV. We've actually played a lot with lower kV rates to see how that can affect our plaque analysis as well as the anatomic assessment in general. But really, you know, scanning these patients, we're in private practice, you know, we're scanning late systole to diastole, so a little longer than you may get when you have a fellow at the scanner dictating what you do. But really, you do get nice high attenuation in the aorta, and you're still, even with acquiring that much data, getting low radiation at 5.1 millisieverts. And you can really answer the question quite nicely. This patient has a severe stenosis in the prox LAD. I also highlight this case. It does show you, even with lower kV, you can still get nice characterization of the plaque. You can see the delineation from the calcified plaque quite nicely of the vessel lumen here, and you can even see the soft attenuation plaque. So even by using these fenestrated catheters with higher injection rates, you're actually able to see the vessels much more nicely, even at lower kV levels. And then this was another patient. Again, this just highlights the plaque characterization. Again, typical patient, 60-year-old male or so with stable chest pain symptoms who underwent coronary CTA, 18 gauge diffuse at 7 cc's per second. He actually was scanned at 120 kV, but had very nice opacification or attenuation in the aorta at 675. And you can really see the vessel nicely. You can see there's no significant stenosis here. It's non-obstructive disease, which was confirmed on FFRCT. So I think another nice aspect of using fenestrated catheters, especially when I've talked about, increasing your CNR, really increasing that attenuation in the aorta, this is really going to help you with larger patients as well. And again, our site's in North Carolina. We've had to look at ways to image larger patients in a more meaningful way. We don't want to preclude anyone from CCTA, and people are not getting any smaller, unfortunately. So what I was commonly taught, at least as I was a fellow and going through things, was when you have an obese patient, you really should just think about cranking the KV. And that's kind of what I was always taught. Go to 130, go to 140. You may see the vessels better, especially the distal vessels. And this was a study which included around 203 patients, BMIs over 30. And they really compared, KV 140 versus 120 imaging. And they really saw no difference in the CNR. So you're really not going to improve your image quality as you think, or at least what I was taught coming along, by just cranking the KV for the larger patients. And you really see here, these are images from that study, which really show you poor CNR, very low image quality, what you don't want to read late at night after you've rounded in the hospital. So one thing we've noticed, just through case examples from our site, is with larger patients, we before, and Michael will talk about this, we used to use angiocasts, 18 gauge, 5 cc's per second. Again, we did this. We would just increase the KV for larger patients. And these are two patients or two case examples of that. So on the left is kind of what we would do before, BMI 48. Some institutions may actually not even scan these patients for coronary CTA. They may choose alternative modalities, preferably probably PET in that instance. But you can really see there's at 140 kV, regardless of how you scan it, at 5 cc's per second, you've got very low attenuation in the vessel. You really can't see the distal vessels that well. There's a lot of noise there, so you really, maybe in the distal aspect of it, may not be able to accurately say, is there a significant stenosis or not. Now, these are comparable patients, another BMI of 48 with an 18 gauge diffuse at 7 cc's per second. And really, it's at 120 kV, and you can see I've got much more attenuation in the aorta, as well as in the LAD, which is shown here. And I can see the vessel very nicely. All of that noise is gone. I can just see very nicely what the vessel is, and I can see this is a very normal vessel. Not the same patient, but very comparable in terms of body characteristics. And then this is just another case. This was a patient with a BMI of 70, and Michael will kind of talk about what we do at our site, especially for these larger patients, who we think about doing or not doing in these instances. This was a patient with a very large BMI of 70, and they really wanted to do, just to make sure the patient didn't have any obstructive disease for preoperative assessment. Not getting into if you should have done this in the first place at all, but it was a question asked for us in the CT lab. And we actually were able to inject at 8 cc's per second with an 18 gauge diffuse and only scanned this patient at 100 kV. Really got high attenuation in the aorta, 605. So you can really see that even for this very large patient who may have been precluded from CCTA in the past, you really can delineate nicely the coronary vasculature, and you can say there's probably nothing here, at least in the prox to mid segments. So this was a nice case example of a patient who you may not get a CCTA on. You may go to PET or other modalities, but if you consider some of these fenestrated catheters, especially diffuse line, you may offer CCTA to a lot more patients. And I'll let Michael's going to come up and talk about kind of our experience before and after, and we'll go from there.
So prior to us having diffusix, we used just a standard angiocath, and we required for all of our CCTA patients to have an 18 gauge IV, and we used the max flow rate of 5 cc's a second. That's pretty much the standard. As with all practices, we've tried to increase our efficiencies and get our appointment times down so that we could get more patients in and reduce our backlogs, but we kind of ran into some time constraints around IV getting the IV. So we were stuck around the 45-minute appointment time slots because we noticed a lot of patients were having to get IV team consults due to the requirement of an 18-gauge IV. He talked about, we were restricted on what we could do BMI-wise. We had a cutoff of 45. Anybody that was over a BMI of 45, we had to do special considerations. So we would view all of their prior imaging to see whether we thought we could actually get good images or not. And that required a lot of QA from our providers. So we were having to call our cardiologists while they were in the office trying to see patients, and that's not a very good use of their time. And we still ended up with lower quality images occasionally. A big driving force for us moving to Diffusix, the reason we started looking for something different was from our nursing staff. They were really frustrated with having to get 18-gauge IVs on all of our patients. So we looked out in the market to see what was out there. We found the Diffusix, we trialed them, the nurses loved them. So now around 90% of our patients are getting 20-gauge Diffusix. So we were able to utilize the down-gauging ability that they offer. So that's really helped our nurses be more confident in getting IVs. There's less IV team consultations happening, so that allowed us to be more efficient with our time slots. So one IV team consult, if you don't have extra time built into your schedule, can really throw the entire day off because that puts everything behind for the patients after that because the patients aren't getting to the CT scanner on time. So with the switch to Diffusix, we've been able to reduce our time slots to about 30 minutes. We could probably get that lower, but just from us doing this in a hospital setting, that's about as low as we can get while still maintaining services for everything else that we do in the hospital. And then as he talked about, we're also able to open up the availability to larger patients. So our new max BMI is 60. You saw we did one patient at 70. I think the highest we've done is a 75 BMI. And that is because we have the higher quality imaging that we can do, and then we don't have to worry about contacting the doctors as much because the techs can tell right off that the images are much better and the doctors will be able to see what they need to from them. So we've been using the standard length Diffusix. We've really been talking to BD because we do have to do a lot of ultrasound guided IV placement. So we have several techs in our CT department and nurses in our radiology nursing department that can do ultrasound guided IVs. And the product that we were using before this precluded us from giving the highest quality imaging because we were capped at a 6 cc a second injection rate. So we've really been asking for longer lengths, and that's something they've been working on. So those came out early this year, and we have been using them. They do have a small trade-off with injection rates for the longer length. They're a little bit lower at each gauge level that you're at, but you're still able to achieve those high injection rates. So even with ultrasound guidance, we're still doing 20-gauge IVs in most of our patients. So this is kind of what we do. We aim for around 65 BMI or less because we use a dual source CT scanner so we can have that a little bit higher rate. We cap our KV at 120, and this is enabled from those high injection rates. So we have the scanner set so that it's going to pick between either 90 to 120 unless the patient has calcium. If the patient has calcium, we're automatically bumping that KV up to 120. And then we do nitrate administration sublingually. Our nurses take care of that for us before we even start the exam. And then we use bolus tracking. You can also utilize bolus timing, but we wanted to keep things uniform across our system. So for all of our other angiography work in CT, we utilize bolus tracking. So we just wanted to stick with that to keep things simple for the techs. And then we use contrast warming. So warmed contrast makes your injections much better. You get a lot better contrast mixing when you're injecting, and it also keeps your peak pressures down when you're injecting, and it helps you be able to reach these max injection rates on these IVs. So this is kind of what our techs and our nurses go by when they're looking at IV placement. So we consider the patient's BMI, and that kind of steers the nursing staff towards what IV they're going to put in. If they feel like they can put in a larger IV, we ask that they do that. So you will see smaller BMIs, as you saw in some of those images that Dr. O'Neill showed you. You did see that they had 18 gauges, and that's just because our nurses felt confident that they could get those, but this is kind of what they go off of. And then these are our injection rates that we typically use. So for 35 and less, we're injecting at 7. Between 35 and 50, we use 8. And then anything over 50, we're injecting at 10 cc's a second. That's typically done through an 18 gauge, but we have had a couple of patients that have been challenging IV access, so we have injected some of those 20 gauge IVs at their max of 10 and not had any pressure limiting issues. So a little bit of differences if you're switching from a standard IV to a diffusix. The biggest difference that we've noticed is insertion technique. So a lot of people, if you are familiar with inserting IVs, it's mainly a one-handed approach. You use your index finger to kind of push that catheter off the needle. When you switch to diffusix, that's kind of a little difficult to do just because of the design. So we've noticed that if you use a two-handed technique and take your second hand and kind of guide it off, that makes you much more successful with your insertions. And then diffusix are a closed system. So if you look at this, they have the pigtail already built into the catheter. So you don't have to add anything onto it. The only difference with that is you have to let blood return flow all the way through that catheter so that when you go and flush it with some saline to make sure it's working, you're not injecting air into the patient. And that's a little different from what we were doing before. The other difference is your peak PSI rating. So these are 325 max PSI versus 300, which doesn't sound like a lot, but that 25 PSI difference really helps you out when you're doing power injection, making sure that you're not going to have pressure limiting issues on your injector. And then the biggest thing for us has been the flexibility with down gauging. So we've been able to utilize this in our CT department for all types of studies. So we've switched from regular angiocath to strictly diffusix for all of our patients in CT. And I think a big example of this is our non-cardiac stuff, our stroke program. So our stroke program, we're always looking to reduce our stroke times because time is brain in the stroke setting. So our stroke department, our coordinator was really looking at time between the non-contrasted head and then the time to getting the contrasted studies. And they wanted to know what was our biggest barrier to getting those contrasted studies, and they talked to the nurses and the techs. The biggest issue was IV insertion. So we required an 18 gauge IV at our site in case that we ever had to do brain perfusions on those patients, and that can be pretty difficult to get. So we looked at that time, and then we looked at what we could do with our diffusix IVs that we have in CT. So our new standard for our stroke patients is 22 gauge diffusix. So we were able to cut 3 minutes off the time from the head without to the contrasted studies, which really helps with our stroke patient care. The other thing is with the way the diffusix are designed, you have a much less risk of extravasation. You have less movement in the vessel, so you don't have to worry about extravasation rates and it being as high as they are with regular catheters. And we have noticed that if you compare our diffusix patients with our regular angiocath patients, the extravasation rate is about 25% less on the diffusix patients. And then the other big thing that we've noticed with our CCTA program is we've been able to reduce our radiation doses by 14%. And while that doesn't sound like a lot in radiology, that's our big guiding principle as ALARA. We're trying to get that down as much as possible. And that's been enabled by the use of diffusix. We have the higher injection rates, which allow us to cap the KV at 120 and not go any higher than that. And something I'd like to point out that's interesting about this drop in radiation dose is while we're increasing our BMI limit. So we're scanning bigger patients, but our dose is still lower overall. So we're going to do some conclusions, and then we'll get to some questions.
Yeah, so thanks, Michael. So yeah, just this was a brief overview of kind of our experience with fenestrated catheters. But really, hopefully, we've kind of shown you the importance of it, how beneficial it's been to our CCTA program. Probably can be beneficial to your program, but these high injection rates are needed for accurate diagnosis anatomically, as well as for other things we use in coronary CTA. So really, I hope that's been impressed upon you, especially if your site's not doing that, or if you may be unaware of what your site's doing, but it's something for you to look into. And I think Diffusix, at least with the fenestrated catheters, in our experience, has really improved our quality, especially amongst our program. We're not being called by the technologists as much to QC images or to look at things, and it's just overall makes your day easier, especially if you're reading 20 studies in a day, which can be quite daunting. And I think the biggest take home for us was in larger patients. We really have something to offer them, whereas before we did not. We kind of strayed away from coronary CTA in the larger BMI patients, but now we just don't do that. And as Michael's really shown here, reduced radiation is a big key. Just by doing absolutely really nothing besides just using Diffusix catheters and capping at 120, we've offered the test to more patients, and we've actually lowered radiation. So that was a big win for our system. And this all goes along with just improved CCTA accuracy. If you've got high quality imaging, you're going to get that answer for the patient that you need, and you're going to get it as quickly as possible. And Michael did talk about other aspects of, what the program has done, or at least using the fenestrated catheters as well as with stroke patients. Our site's set up, and your site may be different, where we're at the hospital. We actually share one of our scanners with radiology, so we do have to fight for time, which is not an uncommon model out there. But if you can be efficient in all aspects of CT, that'll help you open up more slots for cardiac patients, and that's what we were able to do. So I'll stop there, and we can answer any questions you might have. We didn't want to go too long on the first day of SCCT. It's going to be a long meeting. So mainly from not going over 120 kV. So the big thing was in our obese patients, commonly it's always thought just increase the kV, don't think about increasing the injection rate. So just by capping at 120 regardless of BMI, and especially with the long length Diffusix, that really helped us with IV access issues. But just by doing that, capping at 120, larger patients were scanned and radiation went down. Go ahead.
I don't know if you have, we still have some non-volumetric scanners throughout our system. Is there any information on the contrast dose for a 64 detector scanner?
Yeah, that's a good question. I don't think it varies that much because these are all in dual source imaging. And you're asking about, would it vary in those scanners? So not really. You just want to make sure, and Michael showed that kind of formula. You want to make sure you've got enough contrast for about 13 seconds in what you're examining. So with a kind of a dual source or even like multi-segment 4 centimeter detector, 6 centimeter detector where you're stitching multiple beats together or multiple images, that's kind of what you want to aim for. You probably could do less contrast with a volumetric scanner. So all of ours are non-volumetric, so we kind of deal with that as well. But really we go back and we look at the time of the contrast being there and then kind of back calculate. That's kind of how we came up with those contrast numbers for the total volume of contrast you get.
What is the length on those longer catheters?
Michael, do you want to?
They are 1.75 inches, and then the standard ones were 1 inch.
Any other questions? Well, thanks so much. I'll leave emails up here. Please reach out, contact us if you have any questions or concerns. BD should be here through the whole conference. They have a booth set up where you can ask them about fenestrated catheter use, and they can give you more information about that. And thanks for letting us kickstart your SCCT this year.
Thank you.